You can start now.
بسم الله والحمد لله والصلاة والسلام على رسول الله. نتشرف اليوم الجمعية السعودية لصحة الرجل والجمعية السعودية لأمراض النساء والولادة بالتعاون في محاضرة إن شاء الله تكون قيمة جدا بالنسبة للطرفين، للأندرولوجيست وللجاينيكولوجيست. أول شيء أشكر البروفيسور صالح بن صالح، بروفيسور اوف يورولوجي اند اندرولوجي كينج سعود يونيفرسيتي، من الناس البايونير في الاندرولوجي اند يورولوجي. حيكون هو الكي ليكتشرر في السهرة الممتعة إن شاء الله حتكون. أشكر جميع الشركات المساهمة سواء كان تبوك ولا دوبامين. أشكر الحضور اللي أخذوا من وقتهم لحضور مثل هذه الأمسية. حبدأ أنا شوية كده ب10 سلايدات كده تتكلم عن كيف الاندرولوجي والجاينيكولوجي أصدقاء وحبايب دائما. Can I have my share slide please? أدوني البانل. yes, show my screen. Can you see my slide?
Yes.
Yes. Okay, thank you. طبعا أنا كاتب causes of infertility. طبعا causes of infertility is too many. لكن احنا حنتكلم بس عن الميل infertility, male factors. بس خلونا كده لو استخدمنا جوجل سكولر for causes of infertility نلاقي causes of infertility حوالي 600,000 واحد interested in causes of infertility. لو كتبنا male factor infertility هنلاقي فيه تقريبا 500,000، يعني أكثر من النص، أكثر من 3/4 كلهم they are concentrated in male infertility ولا male factor in infertility, which is important. هذا يدلك إنه causes of male infertility is important for not only gynecologists but overall for all people populations. لو ذهبنا إلى male factor infertility in publications ولو أخذنا PubMed for example نلاقي 333 articles published in the last few years. This means that there is not enough publication about male factor in infertility. لو قلنا what are the causes of infertility نلاقي 1/3 of infertile women have a problem with female reproductive system. 1/3 of infertile women has a problem with male reproductive system. And 1/3 maybe they will have both or they are undetermined causes of infertility. لو قلنا how common is infertility نحن دائما نقول it's 15% of women they will have infertility. التكست بوك دائما يقولوا 1 in 10 women they will have a problem if they are between the age of 15 and 44. When we talk about what we know as a gynecologist, أهم واحد عندنا varicocele. If the patient have varicocele, نقول والله خلاص this is a male factor. Although there is so many factors in the male that we as gynecologists, we don't really concentrate on it, like genetic factors, cystic fibrosis, problem with the tight clothes and hot and sauna, injury to the scrotum, low sperm or low testosterone, misuse of anabolic, and this is unfortunately becoming very common, especially with the gym and people they talk together about in the gym about what is the best thing to do. Premature ejaculation, especially in diabetic patient, testicular cancer and treatment, and undescended testicle. So all these factors are very important, but we as a gynecologist, أهم حاجة عندك low sperm. رحت لدكتور الاندرولوجي وقال لك إنه عندك دوالي، خلاص هذه الدوالي يعني إنه عندنا إننا نحن عرفنا نص ليش التشخيص. Although there is so many things more important than دوالي. When we come to the diagnosis, all what we do, semen analysis. And we usually do semen analysis only. We don't do biopsy, we don't do testosterone, we don't do thyroid, we don't genetic, we don't do any scrotal ultrasound, because we concentrate only on the sperm analysis to make the diagnosis that this is a male factor, and always we refer it to the andrologist. And the andrologist they will do the rest of the job. If we go to the evidence, A, consistent with good quality patient orientation, inconsistent with limited quality patient, consistent with the disease orientation. And yes, this is a presentation, preparation for confirmation of ovulation should be obtained with the serum progesterone level at day 21. This is good evidence. Hysterosalpingogram is an important factor. And this is why we do hysterosalpingogram most all of the patients. In unexplained fertility, please do not offer induction ovulation, offer intrauterine insemination, because they are already ovulating. There must be another reason. Women with body fat index greater than 30 is evidence B. In best practice in gynecology, they do not perform immunological testing. Do not perform immunological testing as part of the routine infertility ovulation evaluation. This is by the American Society of Reproductive Medicine. Do not do routine ordered thrombophilia testing patient undergoing infertility evaluation. But please do semen analysis. Semen analysis is important. When we do semen analysis, most of the lab, they refer to the WHO organization 2010. Maybe there is an update now. The reference guideline says that morphology has to be more than 4%, motility more than 30%, sperm count more than 39%, perijac 15 millions, and fertility it must be 58%, and volume at least 1.5%. This is just a brief for our presentation today. Our presentation today is mainly concentrate on something called antioxidant. The antioxidants has been in the market for a long time now. Unfortunately, 1,000 to be more honest, hundreds of companies, they have antioxidants, different antioxidants. Are they useful or not? Are they good or not? Professor Saleh is going to talk about it in subfertility treatment, and why and what and whether it's good or bad. Please, Professor.
Can you see my slides?
Yes, I can see your slide very clear.
So thank you so much, Professor Hassan, and it is an honor for me to participate with a lecture, a webinar, or in the Gynecology Club meeting. And as I said before, hopefully this can be the cornerstone for collaboration between our two societies. Saudi Society of Men's Health have been established in 2018, and its main mission is men's health, including reproductive and sexual health. So I believe collaboration between men's health, women's health, slash urology, andrology, gynecology can result in a healthy reproduction, healthy individuals, and a healthy community. And at the same time, I would like to extend my sincere thanks to Tabuk Pharmaceutical and Dopamine for organizing this meeting. I'll try to be quick and go directly to the subject of today's meetings. I've been tasked to talk about antioxidants in male infertility, subfertility, which is something concerning both andrologists, urologists, and also reproductive gynecologists. As you probably know and aware, these medications are in the market for a long period of time and generates millions and millions of dollars. But we don't know how effective are they, and we don't know what are the best or ideal antioxidant treatment that we can give to our patient to serve them better. At the same time, are we supposed to prescribe them for all comers or for certain type of people? And who is supposed to prescribe them? i.e., if you see an infertile couple, you'll just give the male and female antioxidants, or you just do your part and refer the other party to the concerned specialty, like male to the male urologist. As Prof. Hassan said, infertility is a big subject and represents one of the most common diseases affecting between 15 to 25 of reproductive age couples. We can say with certainty 50% of the infertility factors have a male root. The male factor can contribute solely to 25% and contribute to another 25% in conjunction with the female factors. Now, generally speaking, when we encounter a male factor infertility, these are the armamentarium for our treatment. So we can start by medical therapy if there is a medication that can be offered to the patients. And there are also surgical therapies, and we have also the assisted reproductive techniques. That's the main job of our reproductive gynecologist. And over the last few years, a lot of advancement and innovations have been introduced, whether at the medication level or the surgical therapy, mainly when it comes to sperm retrieval or reconstruction in case of obstructive azoospermia. So how can we classify the medical treatment when it comes to male factor infertility? We can classify them either according to the evidence of dependency. So we have a specific medical therapy, i.e., if you have hypogonadism, you can give a specific hormonal treatment to treat that disease, or we have the non-specific empirical medical therapy. We can also further classify them into according to the drug class. We have the hormonal medications and we have the non-hormonal medication, and the antioxidant therapy falls in the non-specific empirical medical non-hormonal therapy. As Prof. Hassan said, there are a lot of causes for male factor infertility. When we identify a specific disease, really we get happy because we can help our couples. But unfortunately, when the patient falls in the group of idiopathic infertility, then we have this problem and we have the suboptimal results that comes with the treatment. And unfortunately, the idiopathic category can or contribute to a substantial number of our patients. More than a third of them are without identifiable treatable causes. Now, for those with idiopathic male subfertility, we know nowadays there are a lot of things that used to be idiopathic. Now it's more disease specific. Now we know some of those idiopathic male factor infertility, they have a problem with their DNAs, and we have also a good number of them. They have pathological causes related to the free radical induced damage to the sperm. And I will just draw your attention to the molecular structure to the sperm. If you just remember from the medical school, the structure of the human sperm composed of plasma cell membrane, which is a very unique structure, composed of high levels of polyunsaturated fatty acids. This polyunsaturated fatty acids improve the plasma cell membrane flexibility, but at the same time, it makes them vulnerable to be attacked by the reactive oxygen species. And for those who are not familiar with the reactive oxygen species, they are defined as oxygen molecule containing one or more unpaired electron on an open shell configuration. So you can see in the bottom corner diagram here, if you just remove one electron from the outer shell, you will end up by an oxygen-free radical. So based on this, the human sperms are extremely sensitive to reactive oxygen species because of their high content of polyunsaturated fatty acids. So I said polyunsaturated fatty acids are important structural component of human sperms. They are important for membrane flexibility and movement and functionality of the sperm. But at the same time, these are the rate limiting step when it comes to sperm dysfunction. So it can be easily attacked by the oxygen free radicals and in turn destroy them. So, and also there are a lot of disease categories nowadays. We know those. The oxidative stress are implicated as a cause. This can include the natural age process, as well as a variety of diseases like the hematological or solid tumors, obesity or other metabolic diseases, Alzheimer, Parkinson, or other neurological diseases. And nowadays, we know more and more that these oxygen-free radicals play an important role in the pathogenesis of male factor infertility. There are a lot of classes when it comes to radical oxygen species, and you can see in the slide here, these are the most common oxygen-free radicals. Some of them are familiar to you guys, and some of them are being used when it comes to wound cleaning or debridement, like superoxide anions or hydrogen peroxides. Now, we need these oxygen-free radicals. They are not bad altogether. We need a limited production of reactive oxygen species for the normal sperm physiology. They are important for sperm hyperactivation. They are also important for sperm capacitation or a chromosomal reaction. So overall, in a limited number of production, they are important for natural fertilization. But we know infertile male, they have a higher level of reactive oxygen species compared to infertile male. And hence the term oxidative stress comes when we have more production compared to degradation. So the semen in oxidative stress patients is believed to be one of the main factors in the pathogenesis of sperm dysfunction and sperm DNA damage in the infertile male. So when the rate of scavenging becomes less than the rate of production, we end up by oxidative stress, and the role of antioxidant become clearer. Now we have already natural antioxidants in the human sperms. We have vitamin E, vitamin C, L-carnitine, superoxide dismutase, glutathione. They are all natural antioxidants that naturalize the free radical activity and protect sperm from the reactive oxygen species. And we know from the evidence, once those supplements are becoming less in the human semen, then the sperm dysfunction become evident. That can be in the form either decreased concentration or decreased motility, progressive motility, or increased abnormal morphology or abnormal DNA fragmentation. And it has been estimated that 25% of infertile men have a high level of semen oxidative stress. This can be attributed to a lot of environmental and non-environmental factors. We know lifestyle can be a reason for excess oxidative stress. We know also chronic diseases like chronic testicular infections can be a reason. Reproductive infection, reproductive tract infection, UTI, cystitis, prostatitis, fasciculitis, all of them can also induce oxidative stress, and autoimmune factors can play a role here. Also, the increased level of reactive oxygen species can be resulted from, as I said, a lot of environmental factors, such as high temperature, electromagnetic waves in the cell phones, air pollution, insecticides, alcohol consumption, obesity, poor nutrition. All of them play an important role in excess production of reactive oxygen species. Don't forget, leukocytes also are a predominant source for endogenous reactive oxygen species during sperm maturation. And this is unfortunately have been overlooked by a lot of our colleagues, either andrologists or urologists or even gynecologists, when they come to treat or process semen. Whenever you have a leukocytes in the sperms, these have to be treated first before you start any medical therapy, or even before you start IVF. Excess leukocytes in the human semen can induce a lot of oxidative stress, and hence results will not be optimal as you wish. Leukocyte production is also enhanced in obesity, and leukocytospermia is associated with elevated, you can find it by elevated WBC count in the semen when you read it at the bottom. So whenever you have a WBC count more than 1 million, this has to be treated before you start any other procedure with a medical or surgical treatment. Do we have any evidence that from the nutritional related factors that can associated with male factor infertility? The evidence is not that strong, but we have some evidence that the first type of nutrition can increase male factor infertility by disturbing either the sperm parameters or inducing hormonal level changes, or even inducing excess production of reactive oxygen species. You can see from the slides here that the circles with the green color, they have a positive association, and the circles with the orange color, they have a negative association with sperm quality. So we know so far oxidative stress imbalance can lead to a lot of cascades, negative cascades when it comes to sperm health. It can cause sperm cell membrane lipid peroxidation, and this is the chemical reaction that damages sperm plasma membrane lipids. It can decrease membrane fluidity. It can reduce sperm motility. It can increase sperm DNA damage, and I have to emphasize this again and again. Oxidative stress can also disturb or induce DNA fragmentation. Oxidative stress can also decrease sperm oocyte fusion capability and also impair fertilization capacity. Nowadays, also when it comes to medical treatment for oxidative stress, we know we recently have a new assay called total oxyradical scavenging capacity that compare the how strong is that medication compared with the other medication when it comes to fighting oxidative stress or being labeled as an oxidative stress therapy. Now, the question that frequently asked, how would we identify the oxidative stress? The answer is not as simple as what we can expect because the cost and complexity of the testing prohibit commercial kits that can be used for a daily practice. So it's not easy to do them on a routine basis, but there are certain laboratory can provide you with the result if it can change your treatment. But it is costly and very lengthy and complex. We have a direct method and we have indirect method to detect or identify the oxidative stress. The direct method measures the reactive oxygen species, which is the most preferred method. But the problem with this, many reactive oxygen species are extremely unstable and difficult to measure directly. So not a lot of labs have this direct method assay. Most of the labs that can provide you with a number for oxidative stress, they utilize something called indirect method by measuring the damage on proteins or the DNA or the RNA or the lipids or other biomolecules induced by the reactive oxygen species. Don't forget, routine semen analysis can give you also a clue if there is excess oxidative stress, especially when it comes to motility. Motility or progressive motility is the most vulnerable part of the semen analysis that can be affected with oxidative stress. Hyperviscosity in the seminal plasma is another parameter that you should look for. Also, seminal leukocyte count is another factor that we should look at our interpretation when it comes to assessing the production of oxidative stress. Now, I will not spend too much time on this one because it's more of academic slide. So I'll just go directly to how can we treat our patients with excess oxidative stress. Now, generally speaking, the treatment should be directed first of all to reduce or eliminate the stress-provoking conditions like smoking. Ask your patient to start smoking. If there is a varicocele, treat varicocele. If there is infection, go ahead and treat infections. If the patient is exposed to gonadotoxins or hyperthermia, these should be treated to start with. Then antioxidant supplementations comes after or in conjunction with lifestyle modification. And the rationale to use the antioxidant supplementation is based on the premise that seminal oxidative stress is due in part to a deficiency in the seminal oxidations. So if we can increase the number of the level of the antioxidant therapy in the seminal plasma, then we can boost the sperm activity. Okay. Now, what are the various ways for treatment when it comes to oxidative stress and antioxidant therapy? Now, just for our colleagues in gynecology or those specialists in IVF-XC procedures, now seminal plasma plays a crucial protective role against reactive oxygen species. And unfortunately, this seminal plasma is being eliminated when it's come to semen preparation before XC. And that's why we lose a strong defense mechanism against invaders by oxidative stress before we inject the sperm inside the eggs. So its removal during sperm preparation may be hazardous to sperm DNA integrity. And the use of spermatozoa for ICSI will carry the same hazard by excluding the protective role of seminal plasma. And this is the rationale why some labs, they went ahead and the part of their protocol for plasma for the semen preparation before ICSI IVF cycle or IUI even is to supplement the media used by antioxidant therapy. This not have been strongly found to be concrete, but some people are using it. Also, it is advisable to do a shorter centrifugation time. If you decrease the centrifugation time, you can also save some protective role for the seminal plasma containing antioxidant therapy. And last but not the least is to supplement your patient by oral antioxidant therapy before the procedure that you are intending to do, whether assisted reproductive technique or even for natural pregnancy. And we'll come later on during this talk for the what is the evidence beyond this. So what is the ideal antioxidant of choice in male fertility? There are a lot of micronutrients that you can just go ahead and look and Google it or look into the PubMed. You'll find a lot of evidence about a lot of micronutrients. But the most important micronutrients that showed promise when it comes to compacting sperm dysfunction induced by reactive oxygen species are the carnitine, vitamin C, vitamin E, arginine, zinc, glutathione, selenium, coenzyme Q10, and vitamin B12. I'm not going to go through all of them. I'll just concentrate on the most important micronutrients from those during my next talk. Don't forget, essential fatty acids is the energy source for sperm, so it is nice to have it in your antioxidant therapy. Carnitine plays an important role as the energy booster when it comes to sperm motility. Arginine, important for motility and concentration. Zinc, an important trace element for testosterone production, sperm concentration, and motility. CoQ10 is involved in energy production and an important and strong antioxidant factor. Vitamin B12, when it becomes deficient, there is evidence that there is a decreased sperm count and motility for people with deficient vitamin B12. Glutathione, selenium, vitamin E, and vitamin C are all important when it comes to healthy sperm function. This table just illustrates for you what is the recommended therapeutic dose for each one of the antioxidant therapy. And as you can see, if you just go just for 1 second and concentrate on the L-carnitine, as I said, it's very important trace element for motility and concentration. What's available in the commercial productions is a very low quantity of carnitine. And also, when we prescribe it to our patients, we prescribe it in a very low quantity, actually. We give 1 tablet or 2 tablets. Each one of them contain 500 or less of carnitine. And the recommended therapeutic dose is between 2 and 3 grams daily. And you have to be aware, you should not increase it more than 3 grams because there is also a drawback for excess micronutrients when it comes to side effects. I'll just give you briefly some highlights about the most important 2 micronutrients that I consider should be in every antioxidant therapy given to male patients. L-carnitine is a naturally occurring compound, facilitates the transportation of fatty acid into the mitochondria for a beta oxidation. So it's an important element when it comes to energy source for sperm motility. The L-carnitine, which is the L-isomer, is the most bioactive form. So you have to be very careful when you use a specific type of antioxidants containing carnitine, is to use the L-isomer, not something else. The D-carnitine is not active. The L-carnitine L-titrate is not for male factor infertility, and propionyl L-carnitine is also for cardiovascular reasons. It's not effective for male factor. So the most important one is the L-carnitine or acetyl L-carnitine. So for most people, acetyl L-carnitine and L-carnitine seems to be the most effective for general use when it comes to male factor infertility. I'll just skip this. And I'm not going to go through individual studies, but trust me, there are a lot of clinical studies on male fertility showing promising results when L-carnitine is being supplemented in appropriate doses when it comes to improvement in the sperm quality, concentration, motility, and vitality. I'll just skip that because just for the sake of time, you have a lot of studies concluding that the L-carnitine is an important stress element when it comes to antioxidant therapy for male factor infertility. I'll just conclude by this statement from the American Society of Andrology and the European Academy of Andrology. They indicated that the L-carnitine improves sperm parameters, and in particular of the total motility and progenitor motility. They also reduce the level of reactive oxygen species in the seminal fluid and improve the quality of the semen. The other important trace element or micronutrient is the CoQ10. This is a naturally occurring lipid-soluble compound found in every cell in the body. It's the energizer of the cell. So it is a potent energy-producing micronutrient. So it is responsible for energy, for the movement, and all other energy-dependent process when it comes to sperm function. There are also a lot of studies, clinical studies on human sperms and human body that indicate improvement in the sperm quality when it's come, especially for the most important energy-dependent process like capacitation and also sperm penetration and motility and progressive motility after supplementation by CoQ10. The most important aspect of zinc, as you know, it is the second most abundant metal in our body after iron. And it has been estimated by the WHO that zinc deficiency can affect 1/3 of the world population. When it comes to andrology, male factor, it's an important element for testosterone production and hence the sperm concentration and count. And it has been found that zinc levels are generally lower in infertile male compared to people without infertility. Also, there are a lot of clinical studies indicating importance of the stress element when it comes to sperm function. Lycopene in tomato is very important also as a micronutrient and a potent antioxidant. It's important to have it in your antioxidant therapy, and unfortunately not a lot of antioxidant therapy contain that products. There are also a lot of studies that also proving the efficacy of lycopene supplementation when it comes to healthy sperm production. Now, the most important subject, which is also being commonly asked by a lot of colleagues, is what is the role of combined antioxidants? Most of the commercially available and affordable medications or nutritional supplements are combined antioxidants. So is it beneficial to use them, or we just go for individual micronutrient and give it to them? The answer is not as simple as this. You need more than one micronutrient. As I told you before, there are 4 essential micronutrients. To give them on an individual doses, it might not be palatable for your patients, and also the compliance might go down. And hence the idea, can we combine them in one sachet, or we can combine them in one tablet for easier use and optimal therapeutic effect? And hence you have a lot of companies bringing a lot of antioxidant to the market. You can see here in the compare the y-axis with the x-axis and concentrate more on the y-axis, the vertical columns. You see the different concentration for the different commonly available antioxidant therapy in the Saudi market. I'm not promoting any particular individual or individual products, but you can take this picture and you can compare it and you find out by yourself how strong is the concentration of each micronutrient in each supplementation available in the market. The list is very long. I have only here 3 slides for the most commonly used medications, but you can go yourself and fetch it. And before you prescribe any combined antioxidant therapy, please make sure what is the concentration of that medication before you prescribe it for your patient, because sometimes it can be just acting as a placebo effect, because you are not providing your patient with the essential or the recommended daily dose for each individual micronutrient. So is there an evidence for antioxidant therapy use or combined antioxidant therapy? There are a lot of individual studies that have to look at individual medication or combined medication together. Unfortunately, they are heterogeneous criteria for inclusion, exclusion. They are looking at different goals. Some of them are just looking at the semen parameters improvement, and some of them are looking at pregnancy as the end results. So that's why we cannot make a strong conclusion by looking at individual studies. And from this, it comes to the importance for meta-analysis. Cochrane have already done a good job, and they have already reviewed the antioxidant therapy for infertility. There are a lot of revisions to their meta-analysis. The first one was released in 2014, and the last one was released in 2019. This is the most updated review that included 61 RCTs comparing single and combined antioxidants with placebo. They included in this meta-analysis 18 antioxidant therapy versus no treatment or another oxidant in the population of more than 6,000 subfertile men. And they concluded from the Cochrane analysis this slide, which I think this is the most important part of my talk. From the Cochrane analysis review, men taking oral antioxidant therapy had an associated increase in the live birth rate in the IVF patients when compared with men taking the control treatment. So at least we know there is a good beneficial effect when it comes to fertility treated by ARTs. When it comes to natural conception, the role of antioxidant therapy needs further investigation. And as I said before, this is because the evidence that we can get from individual study is not strong. We have a positive association, but that association is not strong to draw a conclusion. So they concluded, the author's conclusion from this Cochrane analysis, and after reviewing the quality of the evidence, they concluded that the antioxidant supplementation taken by subfertile male of a couple attending a fertility clinic might increase the chances for live birth, which is a good statement to start with. However, the overall quality of the evidence was low from only 7 small randomized control studies. Is there a rule for antioxidant treatment on sperm parameters and pregnancy rate in infertile patients after we treat them by varicocelectomy? And this is an important question for our colleagues in andrology or urology. The answer, or the short answer, is yes. Supplementing your patient after varicocelectomy by appropriate antioxidant therapy for at least 6 months showed a positive effect, and this has been proven already by randomized control studies. Also, this has been also proven by a meta-analysis looking at the effect of antioxidant therapy after varicocelectomy, whether you give or not to give. The result is positive and assuring, and encourage my colleagues to use antioxidant therapy after varicocelectomy. As I said before, why we have controversial results, why we don't have a strong concrete evidence from antioxidant therapy when it comes to semen improvement or even pregnancy rates. The answer is simple. Now, if you look into individual studies, the patient selections and for the involved patient or the control patients are different. Not all of them are RCTs to start with. The associated pathology when it comes to male factor infertility is not homogeneous. Some people, they have infection import, some people they have varicocele import, some people they have chronic diseases import. Some studies they use single, and some studies use combination antioxidants. Also, the dose and formulation for the antioxidant is different between different studies. The duration of treatment also is varies. Some of them they use the 6 months cut off before they analyze. Some of them they go as long as 1 year, but some of them they use only 3 to 4 months before they analyze their results. At the same time, we don't have, as I said at the beginning of my talk, we don't have a standardized diagnostic marker for oxidative stress. And also the presence of other molecular or genetic differences between one individual when it comes to response. Some individuals they respond favorably, and other individuals they have a very slow. You need to give them the medication for a long period of time before you start seeing an effect. So, to sum up the advantage and disadvantage of antioxidant therapy, this is the most also important slides here. I would say at least the most available evidence when it comes to antioxidant therapy, we know it can also improve fertilization rate per cycle. The pregnancy rate, there is evidence, although it comes from very few studies, that it can be improving. And we know also antioxidant therapy can improve sperm DNA fragmentation. When it comes to disadvantages, unfortunately, we lack placebo-controlled double-blind design in the majority of the studies available when it comes to obtaining evidence from them. Don't forget also, antioxidant therapy is not a supplement or a way of treatment without side effects. And this is the common saying from some physicians: take this medication, if it doesn't help you, it will not harm you, which is not totally correct, because antioxidant therapy in excess dose can harm your patient. And there is evidence there is a dose-dependent action. At some concentration, a pro-oxidant effect is present, resulting from a prompt for the sperm motility and viability when you exceed the therapeutic level. If you give, for example, L-carnitine more than 3 grams, you have a negative effect on lipoxidation, and hence motility and progressive motility of the sperm. Certain also micronutrients can induce kidney stones, like vitamin C, if you give it in a high doses. Some medications also can be teratogenic, like vitamin A at a higher doses. So from my perspective, if you have to ask me what I think the ideal micronutrient for male infertility, this is what I believe from my experience, my follow-up of patients. I think a combination of L-carnitine, CoQ10, Lycopene, and zinc can be at least the least helpful when it comes to antioxidant therapy. You can increase or add whatever you want, but those 4 elements should be present in any combined antioxidant therapy when it comes to fighting reactive oxygen species. So, in summary, oxidative stress plays an important role in the pathophysiology of male infertility. There are already published studies on dietary antioxidants, including RCTs, generally demonstrate a beneficial effect on sperm function. But the optimal type and dose for the medication or for the supplement is unknown yet. Effect in protecting normal sperms from endogenous reactive oxygen species is not established yet. And the majority of antioxidant studies suffer from lack of placebo-controlled double-blind design, which makes it difficult to reach a definitive conclusion. And the best evidence we have from the Cochrane review database. Keep in mind, early diagnosis of your patient is necessary to avoid progressive oxidative stress-induced damage that might reach to an irreversible state. So this I will come to an end. I'll be happy to receive any questions.
Well, thank you very much. I don't know if there is anybody who can ask question after this comprehensive, very nice presentation. Actually, it has a lot of clinical and non-clinical, even basic knowledge that may be enough for everybody to understand what is antioxidant. But definitely we cannot leave you alone without asking you a question. There's somebody here asking impact on prolonged semen liquefaction time on male fertility and its treatment. Prolonged semen liquefaction time. Does it have an impact on fertility?
Yes. Did you see my picture or the slides already? Do you still see my slides or not anymore?
Yes, we are seeing your slide. We can see your slide is there.
Okay, can you stop sharing my slides? Islam, can you stop sharing my slides?
Stop.
Okay,
Sorry.
so it's okay. So it's an important question. I would like to thank the colleague who asked this, because indeed prolonged liquefaction time indicate ongoing problems. So this is one of the parameters that you look in the semen when it comes to, do you think, is there an excess oxidative stress or not? So the answer is yes. Prolonged liquefaction time can lead to decreased motility and progressive motility, total motility and progressive motility, and hence the sperm function. Now the question why there is a prolongation of the liquefaction time. As you know, liquefaction of semen is the function of the prostate-specific antigen. So when there is a dysfunction in the prostate, whether infection, inflammation, you name it, this can lead to prolongation of liquefaction time, and this have to be treated. The treatment is not to give mucolytic, which is commonly done by our colleagues. This is not the answer. You are just giving a paracetamol for fever. You should identify why the liquefaction time is higher, and we have to treat that, whether it is an infection or inflammation. It's not only just giving a mucolytic, and that will not help your patient in the long run.
Okay, another question here, Sertoli cell only syndrome.
Okay.
How can we treat this problem?
So this is not related to this talk, but the general answer, Sertoli cell only syndrome, is one of the terminal stages for non-obstructive azoospermia. So that patient who have a Sertoli cell only, he lacks germ cells. Germ cells are the cells that produce sperms. Having said that, 25% of patients with Sertoli cell only evident histopathology by histopathology, they still have a small foci of germ cells and sperm production when you look and fetch for them. So there is no medical treatment for sperm cell only, but there is a surgical treatment, which is the microscopic testicular sperm extraction. Once you correct any correctable disease, like if the patient is having abnormal hormones, you treat the hormones. If the patient is having varicocele, you treat the varicocele. After that, you go and do microscopic testicular sperm extraction. 25 to 35% of those patients with Sertoli cell only, you might be lucky to find sperms and use them for ICSI cycles.
Interesting question. Antioxidant agent can be used to prevent aging?
That's true. Actually, we know now and oxidative stress can play an important role in the natural aging process. As I said, also it have been implicated in the pathogenesis of cancer, neurological dysfunctions, and also infertility. So there are a lot of antioxidant therapy now, although the evidence is not that strong, I have to say that, they have been prescribed starting from the age of 40 for people to delay the aging process. But don't ask me, I'm not the specialist or the appropriate person to answer that question, but I can tell you there are already some people are promoting products for this.
This is very good. I'm expecting now Tabuk Pharmacy to send me some antioxidant, please. What about vitamin D? You did not elaborate on vitamin D, and does it have a role as an antioxidant in male infertility or subfertility?
The evidence for vitamin D compared to vitamin C or vitamin E is very low, actually. It is not considered to be an important micronutrient as an antioxidant therapy. It has a lot of biological rules, but not an important one when it comes to male factor infertility.
Actually, this question came from Professor Hassan Farsi, who's a very eminent urologist, and I'm sure you know him. And he's asking, Allah yamsi bil khair. And the next question comes, reduction in during treatment, would you recommend not to use other lab? I mean, I think his question is there is new practical techniques to detect ROS in semen, and I think I can be used before and during treatment. Do you recommend that? ROS in semen.
I think I have mentioned that already during my talk. There are direct assays and there are indirect assays. Most of the commercially available assays are indirect. So they are looking at the effect of antioxidants on the protein, on the DNA, on the RNA. So it's indirect, but it can give you a good estimate of the antioxidant production. But even if they are using the indirect assay, it is costly. So that prohibits its daily use. You cannot just ask for antioxidant assay, the reactive oxygen species assay as a routine like semen analysis or as a routine as a hormones. It is very expensive, and I'm aware of only 2 labs in the kingdom who can afford to do this. Nothing else, because it's not commonly done. It's not commercially affordable. Most of the labs are not interested to jump on this. It's only in a very specialized reproductive centers who do this. And the rationale also behind this, they said, so what? If you know that person have like 300 or 400 whatever number of assay,
Yeah.
you will give the same antioxidant therapy, whether this is yes or not. At the end, you will do IVF, XC, if nothing works out. It is only important when it becomes affordable, with affordable price, to use it to study or to monitor the progress of your treatment. But you cannot make a conclusion in your treatment based on the level of antioxidant or of the reactive oxygen species. So the answer, it is very expensive and you cannot do it routinely.
This Romax, do you think it's enough for treatment of leucospermia?
I don't use it as a personal practice. Most of the leukocytospermia, they respond in my practice to either quinolones or to doxycycline. So for those patients, if I don't have a clear culture evidence of a specific organism that can be killed by specific antibiotics, I give them a 2-week course of either ciprofloxacin or 2-week course of doxycycline, depending on which patient I'm looking at, young or old or middle-aged.
Okay, here a question, maybe very practical. Should we do semen culture in all cases? This is number 1. And if there is antibiotic, empirical antibiotic, we can use till we get the result.
Okay, so generally speaking, I do semen culture for any patients with leukocytospermia more than 1 million, or if less than 1 million, if the patient is going for IVF. Now, based on the culture, I start prescribing antibiotic. There is no need, there is no rush to start an empirical antibiotic before you get the culture. Most of the time, and I have to say this from my practical experience, most of the time the culture comes back negative, but you have leukocytes in the semen. And in that case, I start empirical treatment, but after I have a negative culture. And I have to make sure also the patient have collected the semen in a proper way. Sometimes it's just contamination. So if I know that patient, I give him the clear instruction how to collect the semen in a proper way and still have negative culture leukocytospermia above 1 million per ml, I start either one of those quinolones or doxycycline, vilbramycin, for 2 weeks. And I repeat the semen after that.
Okay. In case if you give somebody antioxidants and then the wife got pregnant after 1 month or 2 months, would you continue for 6 months or you stop it? خلاص.
It's my practice.
I will continue.
It is my belief. I should continue till that patient passed, or till the pregnancy passed the critical period of the first 3 months. So for me, at least 3 months. Maybe you prefer 6 months, but I will not stop it once pregnancy happens until I'm sure that the pregnancy is stable.
And knowing what we know now, maybe he should continue for 1 year because maybe it's anti-aging and it make him younger. Being an oxidative, an expensive treatment. This is an expensive treatment. Do you think it's an expensive treatment? Would you think that it's important to use it? It's not a myth to use it?
Well, if you are still saying it's a myth, that means I did not deliver my message very well. It is not a myth. It is not a fiction. There is a science behind it. But the problem, how to decide on which supplement you will give to your patient. And I hope I have done my job here to if you just finish this webinar by knowing that antioxidant therapy is important, it's here to stay, it's not a myth. You need to give the most essential antioxidant treatment. As I said, carnitine, lycopene, and CoQ10 and zinc. I believe those are the most important trace elements that have to be in any antioxidant therapy. The question that comes after that, you need to provide the appropriate dosage, because if you go to the market, you will see a lot of antioxidants, combined antioxidant therapy. Most of them are in a powder sachet form. Some of them are very cheap. Some of them are expensive. Before you decide whether this is really expensive, you should not take it, or this is cheap, this is better for my patient, just flip the bag and look at the concentration. If you have enough concentration, and I give you one example, L-carnitine. If that medication is not enough to give your patient at least 2 grams daily of L-carnitine, do not use it alone, or just look for another supplement that have at least 2 grams of carnitine. And you can measure this on other trace elements. And I provided a table here for the recommended daily dose when it comes to sperm function that we need to consider before choosing the medication. So please don't be fooled by the price itself before you look into the concentration of each individual combined antioxidant therapy.
Minimal month of using antioxidant?
Well, the sperm cycle should be at least 90 days. We know after 62 days, we might have changes in the sperm parameters, but it's better to stay at least for 90 days, i.e. 3 months, before you say, well, there's an effect or no effect. So personally, I give it for 2 cycles, 3 months plus 3 months. If there is no effect, I don't give anymore.
What about this is outside? Maybe do you recommend computer-assisted semen analysis over the ordinary semen analysis and detecting
Actually, the evidence does not indicate the evidence does not indicate superiority of the CASA over the ordinary semen analysis. So the answer is no.
Okay. Nutrition and fertility means balanced diet, right?
That's
So
right.
why should we start? Why should we start diet and diet and diet from the beginning of life? This is a comment, a nice comment.
Well, this is a philosophical actually question, a comment. Our diet is not healthy, and that's why we should use a healthy diet. So, and this is not easy to strict in our hectic daily life. So, healthy diet is not palatable to start with. It's not enjoyable, I have to say that. And we eat a lot of junk food to make us happy, and that's why we have a lot of oxidative stress.
It's known that vitamin E is one of important antioxidants, but you drop it from your list. Why? Is it because everybody know about it, or because it's not important?
No, actually it is important, and I have already mentioned that in the trace elements when it comes to the first slide of trace elements. But is it important more than those 4 things that I put in from the literature review, from the reading that I went through? Those are the most important thing. That does not mean you should not include vitamin E. I said you need a lot. You don't need one medication. You need a lot of antioxidants, combined antioxidants. Those 4 should be always present in any formula that you are giving to your patients. Adding vitamin E to them is very good, no problem. And I personally give vitamin E 400 units BID with the other antioxidant medication that I give to my patients.
This is, he said, would you recommend that once we take history, physical examination, and send patient for investigation, we start them on antioxidants?
No. The answer is no. Antioxidant is a medical treatment like any other medication. You should use it when it is needed. So if the investigations came back with a patient suggestive of ongoing infection, I will not start antioxidant therapy. I will treat the infection. If the patient comes with in a status of hypogonadism, I should treat hormonal disturbance before. Antioxidant is complementary. So you add it to another medication, or you keep it as the sole medications once everything else has been excluded. And this is actually a reason why some antioxidants didn't work, because we did not use them appropriately. We use them either prematurely before we treat the underlying disease, or we use them subtherapeutic, or we use them in the wrong patients.
Yeah, antioxidants, does it have any positive effect on sexual dysfunction and erection dysfunction?
Well, 2 of them are implicated in the erectile function of individual human male, which are the zinc. As I said, it's a potent trace element for testosterone production and hence potency, and also arginine. Arginine is important for the cavernosal body and blood circulation in the human male organ. This is another antioxidant. It's not important too much for male factor infertility, although there are some studies that indicate arginine is important for motility and progressive motility, but its main function is for the blood circulation in the corpora cavernosa.
Okay. How again? This is time-wise. How long should we continue this medication before IVF or exit?
For the male, I'm not talking here about women. For the male, 3 months plus 3 months. So a total of 6 months.
Okay. Could you highlight on the DNA fragmentation, quick highlight on sperm DNA fragmentation? because it's becoming model أيام هذه.
That's true. I have to
Everybody's
compare. Exactly. I have to compare the people asking about sperm DNA fragmentation assays this year compared to last year, compared to 10 years ago. 10 years ago, nobody's have heard about this and nobody's talking about this. For the last 2 years, people are more interested in the sperm DNA fragmentation assay. But again, unfortunately, they have been tested for or requested for the wrong individuals. We know now, as I said before, like 30 to 40% of male factor infertility causes are idiopathic. Now we know those part of these idiopathic factors are sperm DNA fragmentation or decondensation. So you might have a normal sperms when it comes to ordinary semen analysis. You have a normal shape, a normal motility, progressive motility, but unfortunately the backbone of the sperm, which is the DNA, is broken. And that can explain why we have a lot of failures when it comes to IVF XC cycles. Although we are trying our best to select the most appropriate sperms for injection. Now, sperm DNA fragmentation can give you a clue why we are failing, can give you a clue why there are certain people have idiopathic infertility, although the semen analysis is normal. And for those people, you have to look for factors causing the DNA fragmentation and treat them before you jump into other treatments. But what we know, what I can notice nowadays, sperm DNA fragmentation is being asked for everybody. Now, if you have a patient with low motility, you have a patient with abnormal morphology, you have a patient with leukocytospermia, there is no need to do a DNA fragmentation for him because it will come abnormal. You have a reason for that. But the main cornerstone or the main indication for sperm DNA fragmentation, when you have everything normal and you have nothing to explain why they cannot get pregnant, either natural or frequent IVF cycle failures. That's by that time I go and ask for DNA fragmentation. So please don't ask for it when you have abnormal semen. Ask for it when you have a normal semen to look for other causes.
Okay. What is lycopene?
Lycopene is a macronutrient found in tomato.
What's the natural source of lycopene?
Tomato. Tomato is the natural source.
Tomato. What is the effect of EMF on fertility?
Sorry, what's the effect of?
EMF. I don't know what is EMF.
I'm not quite sure what is EMF.
Can you, the one who asked the question, can he write what is EMF, please? Who can prescribe antioxidants? Gynecologists, andrologists, general doctor.
You don't want me to answer that, right?
Yeah. I think
that's a political question. No,
even if you said andrologist, tomorrow I'm gonna prescribe it.
Well, ultimately, just I want from this meeting is to prescribe it in the appropriate way. That's all. But you know, antioxidant can be prescribed by anybody. I think in my dictionary as a urologist, as a background, I think male factor should be dealt by a urologist, andrologist, and investigation for males should be done by andrologist. Treatment of male should be done by andrologist. I don't think you will be happy if I start treating ovulation failure by a urologist.
But antioxidant can be used for prescribed by female, by gynecologists for female, of course, because we do believe that antioxidant in female have a very good effect on the ovary, and it has improved the quality of eggs during IVF, and I usually mention this. I don't know if you know it or not or heard about it, that in Nigeria, there is a small village that whenever they get pregnant with twins. And people, they were wondering why this happening. They thought it's just a lifestyle. So one of the doctor went there and tried to find out what is the effect, and he found that most of this village, they like sweet potato اللي هي جزر يماني اللي هو البطاطا الحلوة. And it was found that in جزر يماني there is a lot of CoQ10. So CoQ10, and in the United States and Canada now, people, they believe that if they take CoQ10, they might harbor twins. So everybody who wants to get pregnant and she wants to have a twins, she get CoQ10. Of course, companies now, they took it and they make it as antioxidants, capsules, and they calculated the dose, and the dose is about 600 milligram, and it's one of the important antioxidant in female subfertility. So we do know about antioxidant a little bit, not like you guys, but definitely it's effective in female infertility.
I want to be clear, Prof. Hassan.
Yeah.
I don't mean prescribing antioxidants for females. I mean gynecologists prescribing antioxidant for the male.
Yeah.
I think it is not a good practice, and I will not accept that also from urologists who are prescribing medication for his male patient and saying, give the same medication for your wife. It should not happen like this. Specialists should be the one in charge of the medication to give the appropriate antioxidant and to monitor the effect. But gender-specific medication by specialists, of course.
A major problem in our practice that whenever you're treating the husband, the wife, you give her the medication, you tell her, "Oh, give it to your husband as well."
Exactly.
I don't think this is right.
Exactly.
What's the role of antioxidants prior to TASA or micro TASA?
If you are talking about frequent IVF failure with the sperm retrieval, I do give it actually for my patients before retrieval, but not the first one. So the first trial for IVF by retrieved sperms from the testes by either micro-TZ or TZ or TISA, I just go ahead without any medication and I do it. I provide the sperms. But if this failed, yes, I give antioxidant therapy for 3 months at least. Better to be 6 months before another therapeutic retrieval for ICSI cycle. Even if the patient is going for ICSI from ejaculate sperms, ICSI for ejaculate sperms, if there is nothing else, like the semen analysis is normal, I do still give it with the promise that a DNA might be dysfunction causing the dysfunction of the sperm. So I give it also even in a normal semen analysis with the hope that this can naturalize any DNA fragmentation that can happen. Of course, this is better to do it after you affirm DNA fragmentation by appropriate assay.
So maybe this is will be the last question. Why do you prefer to give it in combination, not each one separately? And why it's almost always in sachet, not in tablets?
Well, trust me, I asked this question to different pharmaceutical companies, why it cannot be in a tablet form. And the answer that I got consistently for most of them, it's very difficult to mix all of this macronutrient in one tablet. They are not stable. So this has to do with the pharmacokinetic of the medications. They are not stable enough to be in one tablet form. And the easiest way is to do it in a sachet, in a powder form. So they are more stable. Now, why I don't use individual micronutrients? Because of ease of use. So if you combine all what you need in one sachet, the compliance will be higher. Patient will save more money. Suppose you are taking L-carnitine alone and QQ10 alone, zinc alone, lycopene alone. The combined price for all of this will be higher than any available, the best antioxidant available in the Saudi market will be cheaper than those for individual alone. And at the same time, it's not favorable for the patient to stick to 4 medications every day.
طيب, I think this على فكرة the last question is my question, huh? And you said you asked all the company, and I always ask the same company what, why, and they answered the same. I think the other thing is maybe registration in Saudi FDA will be more difficult if it's in a capsule form. This is one of the answers I got also. But anyway, it was, I cannot express my thank to Professor Saleh, who give a very, very interesting, very comprehensive, basic and clinical, and he answered the question in details that I think now anybody who listened to this presentation, he would know antioxidants in male subfertility and in female, and I think he would know what to do and how he should approach male fertility. Definitely the urologists and andrologists will benefit more than gynecologists, but definitely the gynecologist would understand why the andrologists give the antioxidant. I really thank you very much for the presentation, for the answering the question. I would really like to ask to thank Tabuk and Mahmoud for his great effort in preparing and helping getting this presentation this form. Dopamine has always been with us, and final thank is to الجمعية السعودية لصحة الرجل. And I was talking to Dr. Professor Saleh today about why male are مظلومين, ما عندهم جمعيات كثيرة. يعني جمعية السعودية لأمراض النساء والولادة وجمعية صحة المرأة وجمعية المرأة، إنما الرجل only two years ago they have this الجمعية السعودية لصحة الرجل, although there was the urology society for long period of time, الجمعية السعودية للمسالك البولية. Anyway, it was really nice presentation. Prof. Saleh, again, I would like to ask you and thank you, and hopefully that we will have another presentation, hopefully with the same company, hopefully with different project and subject from that deal with the male and female. Thank you, Prof. Saleh.
Thank you, Prof. Hassan, and I extend my sincere thanks to the Saudi Society of Obstetric and Gynecology for showing the interest, and also to my colleagues in Saudi Men's Health who also showed the interest in attending this webinar. My thanks also to the organizing company, the sponsoring company. I'm looking forward for another fruitful either on-site lectures or another live webinars.
Thank you very much. Wassalamu alaikum wa rahmatullahi wa barakatuh.